Welcome to MedEd's production of Everything Cardiac. This is session number 2, Essential Assessment Skills, and my name is Carol Jacobson. In this module, we're going to do a quick review of some cardiovascular assessment things that you've probably learned in the past, but a lot of times if we don't use these things every day in our practice, we forget some of the concepts. So what I want to do is talk a little bit about blood pressure evaluation, talk about how to evaluate jugular vein distension, and then we'll do a little bit of a heart sounds review. I love this slide. I stole it from a friend. It says, "No patient suddenly crashes. You just suddenly recognize it." The point being that there are usually some subtle things that you can pick up way before the patient's blood pressure tanks or way before it becomes a crisis. So I want to talk about some of those things that you can pick up early to tell you that your patient is about to get in trouble instead of waiting until they're already in trouble. And the main thing is to remember that our body's response to a decrease in cardiac output is sympathetic nervous system stimulation. And that will cause two major things. Number one, the heart rate goes up to try and compensate and maintain blood pressure. So you'll notice a tachycardia. Heart rate is a very sensitive indicator to your body's need for an increase in blood pressure or cardiac output. The second thing is that sympathetic stimulation causes peripheral vasoconstriction. The first blood pressure change that you're going to see when that occurs is an increase in diastolic blood pressure. But some other signs of decreased peripheral perfusion are cool, clammy skin, some poor capillary refill, and a decrease in urine output. But if you wait until you see those things, it's already late. So the first two things that you want to pay attention to are heart rate and diastolic blood pressure. And I think most of you probably have bedside cardiac monitoring that you're able to pull up a trend over the last few hours of particular parameters. So pull up your heart rate and your diastolic blood pressure trend. And if you see the two of them climbing together like this, that's an indication that your body is trying to compensate for something. It doesn't tell you what, but it tells you that the excrement is about to hit the whirling blades, and you would rather that not happen on your shift, right? So this is an early indicator, an increase in heart rate and an increase in diastolic blood pressure. So let's talk about blood pressure evaluation. We take blood pressures because we can, and I have up in the top of the screen there a picture of an arterial blood pressure waveform with the systolic and the diastolic portions of the blood pressure. Remember that the systolic blood pressure is affected by stroke volume, which we've already defined as the amount of blood that's ejected with each beat by the left ventricle. And that's going to be determined by preload, afterload, and contractility, which we just spent a whole hour on previous to this. The other thing that determines systolic blood pressure is how quickly that blood gets ejected into the peripheral system, and that is related to contractility. How strongly can the ventricle eject that volume of blood? And then the third thing is the distensibility of the blood vessel walls into which the blood is being ejected. In other words, how stiff are they versus how compliant are they? If your patient has very stiff, tight blood vessels, as occurs with old age, for example, a lot of older people have very stiff blood vessels, and that will cause their systolic blood pressure to be quite high. A lot of your older patients have systolic pressures of 180 or so, and it's partly related to how stiff those blood vessels are in receiving the volume of blood from the left ventricle. So systolic blood pressure is affected by stroke volume, the rate of ejection of blood into the blood vessels, and how stiff those blood vessels are. The diastolic blood pressure is affected by peripheral vascular resistance, or the tone on the blood vessels. When there's high vascular tone, those blood vessels are tight, and that will increase the diastolic blood pressure. And that's why a rise in diastolic blood pressure is the first blood pressure change that you see when somebody is starting to get into trouble. And that's because the body is trying to compensate by causing peripheral vasoconstriction. If you wait until the systolic pressure has fallen, then it's way late. So increase in heart rate, increase in diastolic blood pressure are a couple of things that you want to keep an eye on as your patient starts to decompensate. We learned that pulse pressure is the difference between the systolic and the diastolic blood pressure, but nobody ever uses pulse pressure. It's becoming way more common in the literature to read about using pulse pressure as a vital sign. So again, the difference between systolic and diastolic blood pressure, normally it's about 40 millimeters of mercury. So for example, if your patient has a blood pressure of 120/80, that's a 40 millimeter pulse pressure, and that's totally normal. The things that influence the systolic part of pulse pressure, again, are stroke volume, and how quickly that volume is ejected. We just went through that. And the part that determines the diastolic part of that pulse pressure is arterial compliance. But keep in mind that arterial compliance doesn't change quickly. That changes over time. So when you see a beat-to-beat change in the pulse pressure, or a change in pulse pressure over a short period of time, like several beats, that's going to be related to stroke volume changes and not to arterial compliance. So a decrease in pulse pressure is an early sign of a decrease in cardiac output. And we said 40 millimeters is a normal pulse pressure. When it's less than 30, that's a pretty advanced sign of heart failure. Keep in mind that the pulse pressure, and again, I'm going to use my hands to illustrate this, systolic and diastolic blood pressure. Pulse pressure can increase either because systolic goes up, and causes of that could be an increase in preload, an increase in contractility, or pulse pressure can increase when the diastolic drops, and that would be because of vasodilation, as in sepsis, for example. So when we talk about an increase in pulse pressure, we're talking about the difference between systolic and diastolic becoming bigger. Things that can cause the pulse pressure to increase again are high stroke volume or high vascular compliance, which means the blood vessels are very dilated. Now, pulse pressure can decrease, meaning that they get closer together, either because of a drop in systolic pressure, which can be because their preload reduced, like they're hemorrhaging or whatever, a low preload, or because they're in cardiogenic shock, their contractility is decreased. That will affect the systolic number. The diastolic number, when it rises, will also cause pulse pressure to decrease. And again, the first blood pressure change we see is a rise in diastolic, and that's because of peripheral vasoconstriction. So those are some things that can affect pulse pressure, and we really should be looking at pulse pressure as much as we do either systolic or diastolic blood pressure. Another thing about blood pressure that we learned, but a lot of times we forget these things if we don't use them every day, is a thing called paradoxical blood pressure, or pulsus paradoxus. This is an exaggerated decrease in the systolic blood pressure that can occur when someone inhales during inspiration. Normally, when we breathe in, there's about a 10 millimeter of mercury drop in systolic blood pressure during inspiration. Up to 10 is normal. And the reason for that is because inspiration increases venous return to the right side of the heart. And the way the right heart is going to accommodate that increased volume is to expand into the pericardial space and get bigger. If the right ventricle is able to dilate to expand or to accommodate that blood volume, then it will accommodate the volume without an increase in pressure. But what happens with systolic blood pressure when there is anything that decreases the ability of that ventricle to expand to accommodate the blood pressure is that the only way the ventricle can accommodate increased volume is to try and shove that septum between the two ventricles, to shove the septum into the left ventricle. That further decreases left ventricular filling. And left ventricular filling is what's going to affect systolic blood pressure. So if there's anything like fluid trapped around the heart, or a tension pneumothorax, which we mentioned earlier, that can also decrease right ventricular filling. Anything that decreases the ability of the right ventricular to expand and fill with blood is going to further decrease the ability of the left ventricle to fill, and that will cause a more than 10 millimeter drop in systolic blood pressure during inspiration. So the way that we evaluate this is to assess the systolic pressure during inspiration and expiration. So here's how you do that. First thing is, you have to have your patient breathing normally, so don't tell them that you're watching them breathe. Don't tell them to breathe normally, just let them breathe normally while you're taking the blood pressure. You want to pump the blood pressure cuff up above their systolic sound and then let it out slowly, as you always do. The first sound you hear will be during expiration. So at that point, stop the air leak from your blood pressure cuff and notice that when the patient takes a breath in, that sound goes away. When they breathe out, the sound comes back. And in my example here, I'm showing that you're hearing it during expiration only at a pressure of about 140 millimeters of mercury. That's the first number. Now, let the air out of the cuff a little bit more, just very slowly, until you're able to hear that systolic sound during both inspiration and expiration. That's the second sound. So in my example here, we're hearing it during both phases of respiration at 120. And then you let the air out until you get your diastolic pressure. So the way you chart this is 140 over 120 over 70. The difference between 140 and 120 is 20 millimeters of mercury. That's a 20-point pulsus paradoxus. It shouldn't be any more than 10. So that is a sign that something is restricting right ventricular filling. It's a lot easier to see when you have an arterial waveform to look at. So if your patient has a radial artery line or any kind of arterial catheter in, you can see that swing in systolic blood pressure. In my example here, during inspiration, the systolic pressure is 116, but during expiration, it goes up to 136. So the way to chart this is 136 over 116 over 84, and again, that's a 20-point pulsus paradoxus. That will be seen with anything that restricts right ventricular filling. Some of the cardiac things that can cause that are cardiac tamponade, which I showed in a previous picture there, blood trapped around both ventricles, in decreasing the ability of both ventricles to fill. Constrictive pericarditis is when the pericardium becomes scarred and rigid and doesn't allow the ventricles to expand the way they need to. So those are some cardiac things. Right ventricular infarction can also cause this, as can restrictive cardiomyopathy. There are some pulmonary things that can cause pulsus paradoxus. Asthma, COPD, a pulmonary embolism, and tension pneumothorax are some pulmonary situations that can create this. And then hypovolemic shock is another thing that can cause pulsus paradoxus. Another thing to review real briefly here is neck vein evaluation. And I will be the first to say that this is not an easy skill. People who have very thick necks, like football players, for example, they don't have necks, right? Their necks are so short and thick that you no way can you evaluate their neck veins. People who have fat necks, it's very difficult. So I'm not saying that this is something that you're always going to be able to do. But if you can see the neck veins, keeping in mind that the right internal jugular neck vein is a straight shot into the superior vena cava and into the right atrium. So if you look at the picture at the top of this slide, see the superior vena cava coming into the right atrium. If right atrial pressure rises, that is going to act just like a manometer, and you'll see the neck veins going up as right atrial pressure rises. Normal right atrial pressure is less than 9 centimeters of water, if you're measuring it in centimeters of water, and it's 2 to 6 millimeters of mercury if you're measuring in mercury. And of course, when you're evaluating neck veins, you're actually not directly measuring pressure, but I'm going to show you how you can kind of guesstimate the central venous pressure based on neck vein evaluation. You want to have the patient positioned at about 45 degrees. In the literature, you'll see two different things. You'll see most of the time they say 45 degrees, sometimes they say 30 degrees. I always learned it as 45, so that's what I go by. But you want your patient at about a 45-degree backrest position. And normally the jugular veins should be no more than about 3 centimeters above the sternal angle. Everything else that's on this slide is just words to describe what I'm going to show you on this one. So up at the top right of this screen, you see the angle of Louie pointed out. The angle of Louie is where the second rib joins the sternum, and that's a landmark that you need to get used to evaluating in your patient. And it makes a little bit of a bump on the sternum, and that is a landmark that we're going to use when we're evaluating neck veins. We know that the angle of Louie, if you look at the picture on the left, that the angle of Louie is 5 centimeters above the mid-right atrial level. If we take a ruler and we put it on the sternum and we measure from the top of that ruler to the height of the neck vein as illustrated in that picture, in my example here, I show the neck vein 7 centimeters above that angle of Louie. If we add that 7 to the 5, we have a CVP estimate of about 12 centimeters of water, and it should not be any more than 9 in order to be normal. So this would indicate neck vein elevation and CVP elevation that is due to several things, which we basically have already said. Anything that increases blood volume or CVP, or anything that increases or interferes with the ability of the right ventricle to fill. So right ventricular failure and tamponade, restrictive pericarditis, all those things that we mentioned, tension pneumo, all of those things are things that can cause the neck veins to elevate. And this is just kind of an eyeball way of estimating what the CVP is based on how high the neck veins are. Another thing that's useful in terms of evaluating neck veins is called the abdominal jugular reflux, and this is a test for right ventricular failure. You may have seen physicians doing this at the bedside when they're looking to evaluate how well the right ventricle can handle an increase in volume. And the way this is done is they put firm pressure over the upper right quadrant of the abdomen while they're watching the neck veins. And again, the patient needs to be at about 45 degrees. And you can't just push and let go. You have to hold pressure for about 30 to 60 seconds. And what you're actually doing is you're pushing blood out of an engorged liver. And that blood is hitting the central venous circulation. It's coming up to the right heart. And if the right heart is not able to handle it, during that time, you'll see the neck veins starting to elevate as right ventricular pressures increase and the right ventricle can't deal with them. If you see a rise in those neck veins of 3 centimeters or more, that's called a positive abdominal jugular reflux, and it's a sign of right ventricular failure. Another thing to be aware of is called Kussmaul's sign, and this is paradoxical elevation of the neck veins during inspiration. Normally, when we breathe in, as our intrathoracic pressure drops and blood comes pouring into the right side of the heart, our neck veins actually flatten during inspiration. But as with anything that restricts right ventricular filling, if there's anything that prevents that increased volume getting into the right ventricle, decreases the ability of that right ventricle to expand and accommodate that volume, pressures will rise and you'll see the neck veins go up. So when neck veins go up during inspiration, that's called Kussmaul's sign. And all of the same things that we mentioned in terms of restriction to right ventricular filling, like pericardial effusions, constrictive pericarditis, cardiomyopathies, diastolic heart failure, right ventricular dysfunction of any kind can cause this physical assessment sign. And then lastly, in terms of this section, we're talking about heart sounds. And we all learned how to listen to heart sounds, I assume, during some phase of our education, either in nursing school or during our orientation to critical care or telemetry or wherever. We all learned this. But this is a skill that you really need to practice, and it's not an easy thing necessarily to learn. So I want to do a little bit of a review of the listening areas and some of the common heart sounds that I think that nurses need to be able to appreciate. The first thing is to remember the best places on the thorax to listen to the different valve sounds. The pink area in this slide represents the best aortic sound listening area. And it's a pretty big one. Technically, it's the second intercostal space, right sternal border. But it radiates quite a bit. Aortic sounds radiate. That's why the pink area is so much bigger. But technically, it's second right intercostal space for the aortic listening area. The pulmonic sound is heard straight across the street. Second intercostal space to the left of the sternum. That's also where your S2 heart sound is heard the loudest. The tricuspid valve listening area is the purple area at the bottom left of the sternum. And right next to that, at the midclavicular line, is the mitral valve sound listening area. And that's also where your S1 heart sound is heard the loudest. So it goes aortic, pulmonic, tricuspid, mitral. All patients take meds. All physicians take money. However you learned it. I learned all physicians take money. But that's the way to remember the listening areas. And it's a good practice to get used to doing it the same way every time. I was always taught to start at the top with the aortic and go down like that. If you want to start at the bottom and go up, it doesn't matter. Just do it the same way every time so that you get in the habit of doing it the same way. And just keep in mind, as you're placing your stethoscope on the chest, which valve sound you're hearing at each place that you place your stethoscope. Remember too, in terms of the stethoscope, the diaphragm of your stethoscope is for high-pitched sounds, and you want to place that firmly on the chest. The bell of your stethoscope is for low-pitched sounds, and you want to just lightly lay the bell on the chest. You don't want to put any pressure on it when you've got the bell, because as soon as you put pressure on it, you're turning it into a diaphragm. So when you're listening to low-pitched sounds, you just want to lightly place the stethoscope on the chest and then either let go or just barely hold it on there if you need to hold on to it to keep it in position. So let's talk about the heart sounds. So let's listen to some heart sounds, or talk about the different sounds that the heart makes. First of all, the S1 sound is closure of the tricuspid and the mitral valves at the onset of ventricular systole. When the heart goes into systole, as illustrated by this picture, the circles are surrounding the tricuspid valve and the mitral valve, and the little arrows on the ventricle are to indicate that the ventricle is in systole. So when the ventricle starts to contract, the tricuspid and the mitral valves need to close so that blood won't go backwards into the atria. And that's what creates the S1 heart sound, is closure of the tricuspid and the mitral valves. The S2 heart sound is closure of the pulmonic and the aortic valves at the beginning of ventricular diastole. So when the ventricles relax, the pulmonic and aortic valves need to close so that blood doesn't come backwards into the ventricles as they're trying to fill. So S1 is closure of the tricuspid and the mitral valves at the onset of ventricular systole, and S2 is the sound that's made by closure of the pulmonic and the aortic valves during ventricular diastole. Both of these sounds are heard best with the diaphragm. The S1 sound is heard best at the apex, which is the bottom part of the heart, and the S2 sound is heard best at the base, which is up at the top part of the heart. And when you see this in writing, this is what it looks like. S1 is the onset of systole, S2 is the onset of diastole. It's easiest, I think, if you try to keep in mind the pictures that I've got up here, so that in your mind you see what the ventricle is doing with each heart sound, because otherwise it's a matter of trying to memorize it, and memorizing this stuff doesn't work. So one trick that I learned when I was learning to listen to heart sounds was to watch the monitor. If I had a patient on a cardiac monitor and I could see it at the bedside, every time you see the QRS complex, you know the ventricle is contracting. So what I would do is I would make my fist be the ventricle. So whenever I saw the QRS, I clenched my fist, and I know that that's systole, and then relax it. You know that's diastole. So S1, S2, S1, S2, lubbed up, lubbed up, lubbed up. And as we listen to some heart sounds in a few minutes, it might help you if you try that with your fist. And I'm going to make my fist do it as we listen to these heart sounds, because that was a trick that I found helpful. Now, obviously, if you're taking care of a patient who's not on a bedside cardiac monitor, you don't have the QRS to look at. But at a normal heart rate, lubbed up and then a pause, lubbed up and then a pause. The faster the heart goes, the harder it is to time it with your fist. But if you can time it, systole, diastole, systole, diastole, that's a skill that may help you as you're learning to listen to these heart sounds. So let's talk about an S3 gallop. And again, we're talking about your ability to pick up a significant new gallop, not that you're going to be diagnosing valve disease or anything like that, but that you can actually just pick up a new heart sound that can be clinically significant. So an S3 gallop is a third heart sound that's heard during the early part of ventricular filling. We said that as the ventricle relaxes, first goes into diastole, you'll hear the S2, and the blood that has been accumulating in the atria will fall passively into those ventricles, and that's what's making that third heart sound. So it's heard after the S2, it's lubdupta, lubdupta, lubdupta. It's an early sign of left ventricular systolic failure, and that's the key thing that I want people to take away, is that it's an early sign of heart failure. Now, you can also hear this with pulmonary hypertension. So if a patient has chronic pulmonary hypertension, they may actually have a chronic S3. Or if somebody is in systolic failure and they come into you that way, you may hear the S3 the whole time they're with you. But we're talking about picking up a new sound, because a new S3 gallop is the earliest sign of left ventricular failure. It precedes your patient's symptoms of shortness of breath. It precedes any chest x-ray changes that can indicate pulmonary congestion, and it's a clinically significant sound for you to pick up and report. Keeping in mind that in kids and in young adults up to the age of about 40, an S3 gallop can be a normal heart sound. But after the age of 40, a new onset S3, keep in mind, is probably a sign of early systolic failure, and it's worth reporting. So we're going to listen to an S3 in just a second. When you see it in writing, this is what it looks like. S1 is lub, S2 is dup, and S3 is ta, so lubdupta, lubdupta. The third sound follows the S2. And you probably were taught that you could use the words Tennessee and Kentucky to tell the difference between an S3 and an S4. That never worked for me. Tennessee and Kentucky sound the same to me, but this helps me. I believe. I believe. I is S1. Believe is S2 and 3. So I believe, I believe, I believe. Lubdupta, lubdupta. So that may help you. So let's listen to an S3 gallop.
Third heart sound. The third heart sound is an extra heart sound that occurs in early diastole just after the second sound. This sound may occur as a normal physiologic variant in children or adults under the age of 40. It is a low-pitched sound that requires the use of the bell of the stethoscope to be held lightly at the cardiac apex. Listen to a third heart sound. I will begin with 3 normal beats and then add the third heart sound.
Try that trick with the fist when you listen to these sounds and see if that helps you when you're listening to these. So that was an S3, and it follows the S2, early sound of left ventricular failure. An S4 gallop is another extra heart sound that occurs early in or late in diastole, right before the ventricles contract. This is a late diastolic sound that is heard when the atria contract and empty their extra volume into the ventricles. You, keep in mind that unless your patient is in sinus rhythm, you will not hear an S4 gallop. So when they're in atrial fib or atrial flutter, you don't hear this sound because the atria have to physically contract in order to create this sound. And this is a sound that is made when the atria eject their volume into a stiff, non-compliant ventricle. It's heard right before the S1. So it's talubdup, talubdup, talubdup. And it's a sign of diastolic dysfunction or a stiff, non-compliant ventricle. And I have in bold on this slide, it's heard in acute myocardial infarction, and that's when you're going to hear a new onset S4. A patient may have chronic S4s when they have hypertension or aortic stenosis or hypertrophic cardiomyopathy or something that's an ongoing problem. But if somebody has an acute infarction, their ventricle will often become very stiff and non-compliant because of the ischemia, and you may hear a new onset S4 gallop. And again, Kentucky and Tennessee don't work for me, but believe me, believe me, believe me. The word believe is the S4 and S1, and the me is S2. So believe me is the S4 gallop. I believe is an S3 gallop. So let's listen to an S4 heart sound.
Fourth heart sound. The fourth heart sound is an extra heart sound that occurs in late diastole just before the first sound. It is low-pitched and requires the bell of the stethoscope to be applied lightly to the cardiac apex. Listen to a patient with a fourth heart sound. I will begin with 3 normal beats and then add the fourth sound.
So that was an S4 gallop, and again, that is a sign of a stiff, non-compliant ventricle. All right, let's talk a little bit about murmurs. Murmurs can be the result of either stenosis or regurgitation. Stenosis is a murmur that's heard when a valve is supposed to be open. I have a friend who says stenosis is heard when a valve is supposed to be open. So that may help you. Keeping in mind that stenosis does not develop acutely. So a new onset murmur is not going to be stenosis. Certainly a patient who has chronic valve stenosis, like aortic stenosis or whatever, will have a chronic murmur of stenosis, but a new onset murmur is not going to be stenosis. Regurgitation is heard when a valve is supposed to be closed, but it fails to close properly and it allows blood to go backwards through the heart. This can occur acutely. So if you hear a new murmur, let's say your patient, you did your physical assessment at the beginning of your shift, patient's heart sounds were totally normal. Let's say they develop chest pain. You should always listen to the heart again with any chest pain episode, and you hear a new onset murmur that was not there before. It's not going to be stenosis. So it can be either regurgitation or one other thing that I'm going to show you in just a minute. So again, I think it's helpful if you can put this picture in your mind. The heart during diastole. Think about this for a second. In diastole, when the ventricle is relaxed, which valves are supposed to be open? Think about this. When the ventricle relaxes, what is it supposed to be doing? It's filling, right? Where does it fill from? It fills from the atria. So the valves between the atria and the ventricle need to be open during diastole. So in diastole, the tricuspid and mitral valves need to be open, and the pulmonic and aortic valves need to be closed, because you don't want blood coming back into the ventricle from those great vessels. So in diastole, you expect your tricuspid and mitral valves to be open. During systole, think about this. What's the job of the heart during systole? The job is to eject. Where does it eject into? Well, the right ventricle ejects into the pulmonary artery, and the left ventricle ejects into the aorta. So those valves need to be open so that blood can flow or be ejected from the ventricles. So pulmonic and aortic valves need to be open. Tricuspid and mitral valves need to close during systole so that blood does not go backwards into the atria. So it's helpful, I think, if you can keep in mind the picture and what the heart is doing during systole and diastole, rather than just trying to memorize these things about heart sounds. So systolic murmurs occur, as would be indicated by their name, during systole, between the S1 and the S2. So it's lub-sh-dup, lub-sh-dup. And I don't do nearly as good a job as the heart sound guy is going to do here in just a minute. But these are valve problems that can result in systolic murmurs. Tricuspid or mitral regurgitation. Look at the picture. The arrows are showing blood going backwards through the valves, back from the ventricle into the atria. That's blood flowing backwards through valves that are supposed to be closed. That will create systolic murmurs. The other thing that will create a systolic murmur is blood flowing forwards through a valve that's supposed to be open. Well, the valves that are supposed to be open during systole are the pulmonic and the aortic valves. So stenosis of the pulmonic valve or aortic valve will create a systolic murmur. We're concentrating here on just listening to left-sided heart valve problems, mitral and aortic, because in the general cardiac adult population, those folks usually have left-sided problems, more so than right. Although if you take care of kids, you'll hear a lot more right-sided problems because of valve problems, because of the diseases and the congenital defects that kids can be born with. And if you have a population of patients who are drug abusers, IV drug abusers, you may hear a lot of tricuspid valve problems. You might have tricuspid stenosis or regurgitation due to the tricuspid valve disease from IV drug abuse, because think about it, when they inject an IV drug, the first valve it hits is going to be the tricuspid valve. So a drug abuse population will have a higher incidence of right-sided problems, but we're just listening to left-sided valve sounds here. Now, the other thing, if you'll look at the picture, the other thing that can cause a systolic murmur that's new is a ventricular septal defect. So I drew my yellow arrow through the septum to indicate that if somebody develops a hole in their septum, which can occur acutely as a complication of myocardial infarction, a new ventricular septal defect will present as a new systolic murmur. And if they have hypertrophic cardiomyopathy, obstructive cardiomyopathy, that creates a systolic murmur that is very similar to aortic stenosis. It sounds the same. It's just it's not the valve, it's the outflow tract that's stenotic. So when you hear a new onset systolic murmur, especially in an acute MI patient or somebody with just acute ischemia, that can be a sound that you hear because of acute mitral regurg due to papillary muscle dysfunction, either ischemia or rupture, or a new ventricular septal defect. They've just blown a hole in their septum. Both of those problems, papillary muscle dysfunction and a VSD, can be side effects, or I should say complications, of acute myocardial infarction. So again, we're talking about detecting new onset murmurs that need to be reported right away, especially papillary muscle dysfunction that causes acute mitral regurg. That can result in acute pulmonary edema, and it's a big deal. Patients decompensate right in front of your face, so you need to be able to recognize that murmur. So let's listen to mitral regurgitation.
Murmur of mitral regurgitation is holosystolic and is heard best at the cardiac apex. This murmur is high-pitched and blowing in character. Listen to a patient with mitral regurgitation. I will start with 3 normal beats and then add the murmur.
Hopefully you were doing the trick with your fist so that you could tell systole from diastole. And again, when you hear that sound when your fist is clenched, that's a systolic murmur because your fist is in systole just like the ventricles are in systole, if you try that trick. All right, aortic stenosis is the other murmur that will create a systolic sound. So let's listen to aortic stenosis. It sounds quite a bit different from mitral regurg.
Aortic stenosis. The murmur of aortic stenosis is systolic and harsh in quality, and is heard at the second right intercostal space with the diaphragm of the stethoscope. Listen to a patient with aortic stenosis. I will begin with 3 normal beats and then add the murmur.
That was aortic stenosis. Sounds quite a bit different, but again, both mitral regurgitation and aortic stenosis are systolic murmurs. Which one is going to be an acute problem? Not stenosis, right? So a new onset systolic murmur is either going to be mitral regurg or it could be a ventricular septal defect. All right, how about diastolic murmurs? These are heard after S2 because S2 is the onset of diastole. So it's lubda psh, lubda psh. You hear the murmur after S2. Think again about when the ventricle is in diastole, its job is to fill. Where does it fill from? It fills from the atria. So if the tricuspid or mitral valves are stenotic, that will present as a diastolic murmur, which is blood flowing through the valve that is supposed to be open. The other thing that will cause a diastolic murmur is blood flowing backwards through the valves that are supposed to be closed during diastole, and that's the pulmonic and aortic valves. So diastolic murmurs in terms of the left-sided valve problems will be either mitral stenosis, which will not be a new onset thing, or it could be aortic regurgitation. And that can occur acutely. The time when you might hear a new onset diastolic murmur would be if your patient has an aortic aneurysm that involves the arch of the aorta, and that aneurysm is dissecting backwards towards the valve. It can create acute aortic valve regurgitation, and that will present as a new onset diastolic murmur. It's way less likely that you're going to hear new diastolic murmurs than it is that you will hear new systolic murmurs. So let's listen to mitral stenosis. Mitral stenosis is actually my favorite murmur, although it's kind of hard to hear, but it's very interesting. It's got a lot of parts, and you can actually dance to mitral stenosis. But let's see if we can listen to mitral stenosis here.
Mitral stenosis. This murmur is by far the most difficult one to identify. This diastolic murmur is low-pitched and rumbling in character, and can be easily missed unless the clinician uses the bell of the stethoscope applied lightly at the cardiac apex. Listen to a patient with mitral stenosis. I will start with 3 normal beats and then add the murmur.
It's just an interesting murmur. You didn't get to hear probably as acutely the opening snap. That's when the valve leaflets first snap open. It makes an extra sound. It just kind of gives a little dance-like quality to the murmur. And all of these extra things like opening snaps and split S2s and all this stuff, we're not getting into all that here. I'm just trying to talk about the things that I think are the most important for you to be able to pick up acutely. And again, mitral stenosis will not be an acute problem because stenosis takes decades to occur and to create abnormal heart sounds. Aortic regurgitation is another murmur that is a diastolic murmur, and this can be an acute thing. Again, if the patient has an aortic arch aneurysm that dissects backwards and affects that valve, you might hear a new onset regurgitation murmur. So let's listen to aortic regurg.
Aortic regurgitation. The classic murmur of aortic regurgitation is a high-pitched, diastolic, decrescendo murmur, usually heard in the 4th left intercostal space. Listen to a patient with aortic regurgitation. I will begin with 3 normal beats and then add the murmur.
It's a real high-pitched sound. It almost sounds like a gunshot a little bit, quite different from the other murmurs that we've listened to. So that's just a quick review of some physical assessment things. Blood pressure evaluation, it can tell you way more than just systolic and diastolic pressure, neck vein evaluation, and heart sound evaluation.